Hello. Today I would like to present one of the most important maneuvers which can help to determine presence of accessory pathway, especially the accessory pathway located in the area of bundle of His. In previous video I described the role of incremental and in general of ventricular pacing, during which we can easily prove the presence of left-sided accessory pathway. So just to remind you, in case of the right ventricular pacing, if there is a pacing artifact and when we've got the left-sided accessory pathway, typically in the catheter located in coronary sinus, we should register eccentric activation of the atria. So the earliest activation should be in the distal parts, distal electrodes from CS catheter. And in this case, there are no doubts that we've got the patient with the left-sided accessory pathway. The problem is when we've got the patient with the accessory pathway located close to the septum, close to the bundle of His, because in this case, we've got the concentric activation of the atrium. Of course, we should check the conduction, is there a decrement or not, but this can be also a little bit misleading, so that's why in this case we should perform the para-Hisian pacing. Let's look closely on the area of bundle of His. When we are close to the bundle of His, we should register the electrograms like this. So the small electrogram, the first one, which is the atrial activation, then quite sharp electrogram, which is the electrogram of bundle of His, and then much more bigger electrogram, so the electrogram of ventricles. So this is important for the next parts of the para-Hisian maneuver to be sure that we are in the good area. Okay, so then let's look what's going on during the ventricular pacing in the area of bundle of His. Okay, now let's look what's going on when we've got the pacing in the area of bundle of His in patients without the accessory pathway. So of course the septum is quite thick structure, the bundle of His is quite inside, so when we start pacing with the lower voltage, so if there is the intraventricular septum, the bundle of His is a little bit inside. So when we start pacing with the smaller voltage, we just pace this area closer to the endocardium and we don't pace the bundle of His. So in this case the QRS complexes are quite wide, so the same as the typical normal ventricular pacing. So we've got quite wide QRS complexes. Of course we've got the artifact of the pacing from the catheter in the right ventricle close to the septum, and then when we pace in this area with smaller energy, so we just pace the muscle, the impulses goes down in the area of the apex of the heart, and then through the Purkinje fibers and heart conductive system comes back to the atria, so also through the bundle of His, and comes back to the atria. So in general, the distance between the artifact of the pacing and the activation of the atrium is quite big. And this is the time which is corresponding with the time of conduction through the muscle and then through the conductive system. Okay, but when we use the higher energy, so when we use the higher energy and the pacing from the same part, we can pace not only the muscle of the intraventricular septum, but also we pace the bundle of His. So in this case, when we use the higher energy and we pace the bundle of His, QRS complexes are narrower, and then if there is no accessory pathway, just after the pacing, activation of the atria is much more faster than in the patients with accessory pathway. Because in this case, when we've got the pacing of the bundle of His, we just pace this area and the impulses comes straight retrograde to the atria. So if we've got the difference in SA interval, so the interval between the stimuli and the first atrial activation, when it's longer, when we pace with the lower energy, so QRS complexes are broad, and then when we use higher voltage, QRS complexes are more narrower, and this distance SA is shorter. So let's say this is SA1, this is SA2, and physiologically SA1 should be longer than SA2. Okay, now looks what's going on in patients with accessory pathway. So when we've got the accessory pathway, it's a parahesian, so it should be close to the bundle of His. Again, we perform the same maneuver as before. So now let's start pacing with the lower voltage. So QRS complexes are quite wide, and then we perform the pacing with higher voltage, so QRS complexes should be much more narrower. So we pace from this area, so close to the bundle of His. And in this case, it doesn't matter if we pace just the muscle or we pace the muscle and the bundle of His. Still, the fastest way for the impulses to come from the intra-atrial septum to atrium is through the accessory pathway. So this is the faster way to reach the atrium. So it means that in this case, when we've got the pacing with the wide QRS complexes and the pacing with the narrow QRS complexes, in both situations the interval from the pacing, so the signal of pacing, artifact of pacing, and the activation of the CS is exactly the same, because in both these cases, SA1 and SA2, in both of these cases we've got the conduction through the accessory pathway to the atrium. So there is no conduction through the muscle and then Purkinje fibers, and from the conduction system all the conduction is through the accessory pathway. So when we've got the SA1 interval which is equal to SA2 interval, it means that in this case we've got the parahesian accessory pathway. So the most important is to check is if there is a change of QRS morphology. If it's true, if we've got the broad and narrow QRS complexes and the same SA1 interval as the SA2 interval, it means that in this patient we've got the accessory pathway which is located close to the bundle of His. And in the end, I would like to tell you about the one pitfall which is or maybe quite common and maybe misleading and may cause that it's hard to conclude this maneuver. It can happen especially when we've got the signals registered by the catheter in the right ventricle like this. So we've got the quite big atrium, then small signal of the bundle of His, and then we've got the ventricular signal. Because in this case, especially with the higher voltage, it's possible that during the pacing we may pace not only ventricle but also the atrium. So we've got capture in the ventricle and in the atrium. And in this case, when we've got the capture in the ventricle and the atrium, it doesn't matter what shape of the QRS complex. Is it narrow or it is a broad QRS complex, we pace the atrium also. So we've got the capture in the atrium. So typically electrograms will look like this, that we've got the ventricular pacing, and just after the ventricular pacing we've got atrial signals in the catheter in coronary sinus. So it may be misleading. You may think that, oh, the SA interval is the same, so I think that in this patient there is a parahesian accessory pathway, but it's also worth to measure the SA interval. So the SA interval. So if the SA interval during the parahesian pacing is shorter than 60 milliseconds, it means that there is the atrial capture and we should move the catheter in the right ventricle a little bit deeper to pace bundle of His and the ventricle and to lose the atrial capture. Okay, thank you very much for today. I will encourage you to perform this maneuver because the practice is very, very important, and with this maneuver you can easily differentiate the patient with and without the accessory pathway close to the bundle of His.